carefully at whether there's additional evidence for persistent and pervasive changes along these lines. Some patients may not describe sadness or decreased interest or lack of enjoyment, but they'll report pessimism or hopelessness, what we call negative ruminations. They may have inappropriate guilt, a negative view of their sense of self. There may be morbid or suicidal thoughts, talking about their death, talking about the end of their life, even when they're really very early in the disease and are minimally affected by the disease. Or they may just feel overwhelmed, anxious, unable to cope. Many patients will say, I can't cope because I'm depressed. But in actuality, what happens is if you're depressed, you really can't cope. And time and again, a patient will say, I can cope with Parkinson's disease, but not if I have depression. When you treat that depression, they're able to cope with all the difficulties that the disease itself presents. And some patients will have irritability as an important or prevailing feature of their depressive disturbance. So it's important to ask about all of these different emotional features of the disease, of the disease depression, that is, in the context of having co-occurring Parkinson's disease. There are also other disorders that occur with Parkinson's disease. Anxiety is one of the other common mood disorders, affecting up to about 40% of patients. Its onset can precede Parkinson's by many years, as I'll show you some additional data. Often, anxiety will accompany depressive disorders, and it is not an understandable reaction to the motor symptoms. This is excessive pathological anxiety that's unwarranted and is also treatable. However, there haven't been treatment trials to date. There's a spectrum of anxiety disorder subtypes in the general population, as well as in Parkinson's disease. That includes things like panic disorder, generalized anxiety disorder, or phobias, as well as some PD-specific conditions, in particular problems with anxiety or panic attacks when a patient is wearing off of their anti-Parkinson's medicines, and I'll describe that further. Just to mention briefly, we talked about Parkinson's related depression occurring before the onset of Parkinson's disease, and we mentioned that depression can precede, at the lower part of the slide, Parkinson's by about 4 to 6 years in the literature. Anxiety, however, seems to occur even earlier than depression, occurring in some studies up to 20 years before the onset of motor signs, suggesting that there may be a different course for anxiety relative to depression in the degeneration of the brain neurons. And this is a slide that also comes out of our Mood PD study. It's unpublished data, but showing how we see the duration between the anxiety disorder onset and the PD diagnosis, with the PD diagnosis being at time 0. And you have some patients with 66% of the patients had anxiety before their PD diagnosis, occurring even up to 60 years before their diagnosis of PD, and about 34% having the diagnosis of anxiety after Parkinson's disease began. What we see, though, is a high prevalence of select anxiety diagnosis. I mean, this is looking at the current as well as lifetime prevalence of different anxiety disorder diagnoses. So you see here in red, panic disorder occurring about 13% of patients over lifetime, social phobia in about 11%, and a specific phobia in about 24%. And these are higher than what you would see in the general population, as well as what you see is a slightly later onset. So panic disorder beginning in their 40s, whereas typically panic disorder would begin earlier in adulthood in the general population. We also, on the bottom row, see a high proportion of patients with non-specific anxiety disorders that really don't fall into any specific DSM-4 criteria. And these are what fall into the category of anxiety disorder not otherwise specified. And about almost 40% of patients had these anxiety diagnoses, and they had a median age onset of 60, which is really about the time when these patients were having the onset of their Parkinson's disease. These data prompted us to look more specifically at the panic disorder patients with the idea that they may be an important subtype that's etiologically significant. And what we see here in the panic disorder patients compared to the non-anxious patients is an earlier age onset, of Parkinson's disease, in particular, with those patients having onset of Parkinson's around age 50, whereas the other non-anxious patients with their Parkinson's beginning at age 61, they also had more complications of their Parkinson's therapy with motor fluctuations or on-off fluctuations, unpredictable wearing-off symptoms, more problems with morning dystonia, as well as worse quality of life measures, a family psychiatric history, as well as a positive lifetime history of depressive disorder. The fluctuating mood states, which I mentioned, are a tremendous problem for these patients with anxiety. So when patients take their Parkinson's medications over time, when they wake up in the morning, they will be considered off without normal motor movement. And as they take their levodopa, for example, at 6 a.m. in this slide, they will then have the onset of normal motor function when they would be considered on. And if they're having problems with dyskinesias, which are choreiform motor movements, or dyskinesias as they're called, they will then have those at the peak of the dose. And then as the medicine wears off over a 3-hour period in this example, then they will they will go back to having decreased motor function. So the motor state you see fluctuates in the red bar from off to on to dyskinetic and then back to being off again. And in some patients who have these motor fluctuations, what you also see is a fluctuation in their mood state, so that when they are off, they will be anxious or sad, and when their motor function is better, they will be having a neutral mood. And some patients may even have a hypomanic mood at those times. And then as their medicine wears off, they will go into an anxious or panicky state that will then resolve as their medication is taken again, and they go back to being in a neutral or an on motor state. And so their life goes on this roller coaster of motor function and emotional functioning over the course of the day. What's important is that the patient will look very different if you examine them at noon when they're in an on state versus if you examine them at 4 p.m. when they're in a state of absolute panic or dysphoria. And so it's important to ask patients not just about their mood in general, but whether their mood fluctuates over the course of the day. Because in a case like this, you wouldn't start off with treating them for a panic disorder or for a depressive disorder, but what you would want to do is address their anti-Parkinsonian motor regimen and smooth out their motor function so they don't have these kinds of fluctuations. And there are medicines that can address that. Apathy is another common problem in Parkinson's disease, affecting about 30% of patients, often seen as a feature of a depressive disorder, but it also can occur as an independent disorder. And what you see is loss of motivation, emotional indifference, reduced goal-directed activities, and often it's the family members who complain, because patients with primary apathy really do not complain. That's a feature of the disease itself. A feature of apathy itself is that the patient is indifferent to their problems. What we frequently see in apathy is an overlap with depression as well as cognitive impairment, which makes it even more complicated and potentially difficult to diagnose. So how do you distinguish apathy itself from Parkinson's disease? Just like depression, where there's considerable overlap of the basic symptoms of Parkinson's disease, you also see the same overlap with apathy and Parkinson's disease itself. So in the middle column, you see the signs and symptoms that can occur with apathy or with Parkinson's disease. The absence of facial animation will be the masked facial expression that's part of Parkinson's disease, or indifference that's part of apathy or amotivation. The decreased body language, or paucity of body language, is bradykinesia in Parkinson's disease, or it can be the lack of effort in a patient who has apathy. The monotonous speech and the soft speech can be the hypophonia of Parkinson's disease, or just the flat affect of a patient with apathy. The reduced spontaneous speech can be a feature of cognitive dysfunction or passivity. And then the reduced socialization and the reduced interest in hobbies can be a problem that you see with bradyphrenia in Parkinson's disease itself, or the withdrawn behavior of a patient with apathy or amotivation. Emotionalism and pathological crying, I've mentioned, also occurred in our case example early on. This occurs in up to 40 to 50% of patients and is associated with depressive disorders, delirium, and benzodiazepines, but can also be a problem in its own right. It is basically described as heightened or excessive emotional